we're at the Pentax Symposium, so I show you colitis-associated dysplasia. And if you look very carefully, looking with eye scan in addition, you see there are some dark remnants in that lesion. And that is from a new drug. It's called methylene blue MMX. So you take these pills during your colon preparation, and then you have your colon staining very well standardized, and that might be a new approach how we can refine surveillance. However, we have to talk whether our colonoscopy is efficient or not, and that was a long debate. Now the debate is over because New England Journal of Medicine this year showed we are doing good to our patient, and you see there's a clear reduction in a hard endpoint mortality of 53%. 53% sounds good, but if I would do a colonoscopy on you, you would ask for 100%, and the question is, well, we do see problems. And maybe this is highlighted by that Canadian study where they showed on one hand also reduction in mortality of 30%, but if you look very careful in that data, you see that on the right side of the colon, almost no decrease of mortality is seen. So we do miss something, and how can we overcome our miss rates of adenomas and maybe cancers? And there's a substantial paper by Dr. Rex, one of the well-known colonoscopists of the US, and he did in 1,000 patients retroflex colonoscopy. And I was taught not to do so, but now with the more flexible endoscopes, which are also delivered by Pentax, you can do, and you see there were no, sorry for this one, no perforations, and a technical success rate of about 95%. I show you one of my videos, so you can easily go into the cecum, you do the retroflex, and then you can really carefully look behind the folds. And that is necessary because you like to see those flat and maybe serrated lesions, which are much more common on the right side of the colon. And then it might be very important to see these subtle changes to identify those and do the biopsies, because that is something which is maybe a substantial risk for the patient if you do not remove these small lesions. And even in experienced hands, you see the missed adenoma rate was 10%. And if you calculate that on a per patient analysis, almost or more than 4% of your patients will go home. You think there's no adenoma, but after retroflex, you will identify them as having at least one adenoma. Very similar is the third eye retroscopy, where you have a fiberoptic endoscope looking behind the folds, and there are 3 studies with 2 interesting designs. That is the best study because they did a tandem colonoscopy, and they looked what is the value of the second colonoscopy, how much do you miss, and with third eye retroscope, they could identify 46% additional adenomas. They could identify by doing regular second colonoscopy 23. That's why you see here, that is the diagnostic yield with what we miss. That's substantial numbers. But the crucial question is, how many cancers do we miss? And what time or interval cancer mean that in that time when we say to our patients, come back in 4 years, 2 years, or 10 years, he or she feels safe, but then develop a cancer. And you see, here's the answer also from New England Journal of Medicine. See over 45,000 persons in Poland, and then there were 42 interval cancers. Maybe not too many, but there are some, and there are 2 independent risk factors. On one risk factor, we cannot change anything. This is the age of the patient, but the adenoma detection rate is of crucial importance, as you can see here. The adenoma detection rate of a single endoscopist exceeding 20% has almost no interval cancers. All the other endoscopists, less than 20%, they have problems. So my first conclusion, and I have 3, is that colonoscopy remains the gold standard, but there are for sure ways to improve, and also to improve ourselves to have maybe at least an adenoma detection rate above 20%. So what is then the true value of high definition plus endoscopy, and chromoendoscopy as well as virtual chromoendoscopy in that sense? I'd just like to show you the new series of Pentax, where you not only have the eye scan possibility, and it's called contrast or tone enhancement, or you can call it iScan 1, 2, and 3. You see here that you also have the possibility to do zoom endoscopy, but sometimes you get frustrated because you are not sure whether this enhanced image truly shows something which is of value, and that's why you have this twin mode where you see all the time your white light endoscopic image, then you have here your enhanced image, so you can compare all the time what is relevant or not, and I think that's a substantial improvement and advantage compared to the NBI system, what you can only switch on and off. Here you have the direct comparison in high definition. If you look back into the older data of high definition, you see that your additional diagnostic yield is almost less than 4%, which is maybe only moderate increase. But if you're at the 16 or 17% working, maybe that additional 4% leads you to overcome the 20% adenoma detection rate. However, if you look in a more head-to-head comparison here, standard definition against high definition with NBI, or starting with high definition NBI with standard definition, which was a randomized controlled trial, you see if you start with standard definition, you miss 49% of adenomas. If you start with high definition, it is much less, but still 27% of adenomas are missed. Also, if you look on the true value of NBI, if you switch it on all the time, you see there's no additional value compared to a high-definition white light. So it's true you can use virtual chroma endoscopy, not for a better detection, but maybe for a better characterization of lesions. And here's a very interesting study that very rarely is done. So you see the head-to-head comparison between iScan versus NBI for the characterization of polyps, meaning that you can predict histology. And you see here the numbers, sensitivity for NBI below 90%, 89%, and for iScan 95%. So there was statistically no significant difference. However, I think 95% to be accurate, that is absolutely in line with the PV guidelines, which were published from the American Society. Coming to FICE, the same. FICE does not show you a better detection. However, it is in the same sense as real chroma endoscopy with indigo carmine, accuracy 94% in that study, and with FICE 88%, so below 90%. So the take-home message is, for virtual chroma endoscopy, you cannot better detect, but you can better characterize. What can you do to even better detect? You can combine high-definition endoscopy with chroma endoscopy. And yes, I still like using methylene blue. And you see here that was done with indigo carmine. Patients having at least one adenoma, if you do pan-chroma endoscopy, 46%. With white light endoscopy, only 36%, which was a study done by Jürgen Pohl from the Wiesbaden group. To show you the difference and that you add something substantially if you do the staining is that video. There you see colon cancer. You don't see the colon cancer? Have a careful look. Maybe you use the iScan technology to have a very careful look on that area here. So now iScan on, and there's maybe erosion. Could you differentiate? Could you diagnose here? What kind of lesion is it in terms of Paris classification? Use a little bit of methylene blue or indigo carmine, and then you see very clearly this depressed early colorectal cancer. And as you know, 5 millimeters in size, in 50% you have a submucosal invasion. So I think there's still a value of chroma endoscopy in combination with high definition plus endoscopy, even if you have all the modern virtual chroma endoscopy tools. And that is for sure true chroma endoscopy in patients with long-lasting ulcerative colitis. And here, this is a patient having at least 15 years of colitis. You see the lesion somewhere here. You have to clean that. Then you see the lesion much more obvious. You can use iScan to further unmask the borders of the lesion, or you can use chroma endoscopy, which really nicely show you the difference between the unaffected mucosa and the affected mucosa. And there's a low yield of random biopsies, and that was the question before from Barrett's esophagus. These are the data from the Netherlands. You see 10 years of surveillance, more than 1,000 colonoscopies. If you break it down, there were only 5 colonoscopies when random biopsies dysplasia was found, but only in 1 colonoscopy it led to clinical consequences. So there is a value of chroma endoscopy to unmask lesions, to clarify the borders, and then you can target your biopsies. And that is another case. You see here the rectum, patient with long-lasting ulcerative colitis. There's no lesion visible, but now we use chroma endoscopy to further define the mucosa. I like to use methylene blue in a final concentration of 0.1%. Here it is done in an untargeted fashion, meaning that this whole segment is stained. And immediately, even before it is absorbed, you can have a view onto the mucosa. And here I use the zoom colonoscope, and you can see the normal colonic crypts here very nicely. And still the vasculature can be seen if you use that diluted methylene blue. But it's even more important not to look onto the mucosa architecture, but more to identify lesions. And that's a lesion type 2B, completely flat, you see here. It's not elevated, but there's now the border seen after chroma endoscopy. And it does not mean that if you do a targeted biopsy on the lesion, you always will find dysplasia, but your probability to find dysplasia is 5 times higher than without any lesion. And there's a proved value of chroma endoscopy in patients with ulcerative colitis. There's a number needed to treat of 14, and you will find one more patient having colitis-associated dysplasia or intraepithelial neoplasia. So there's a good value for virtual chroma endoscopy to characterize. There's a good value for chroma endoscopy to detect, and especially in patients with long-lasting ulcerative colitis, chroma endoscopy has established as the new standard. Now, very short, it's endomicroscopy, and that is looking onto the cellular level and looking from the mucosa up to the deepest parts of the mucosa, and that with a resolution less than 1 micrometer, which leads you to identify subcellular changes. And you look on the pattern, the vessel architecture, as well as the crypt architecture, and to answer that very important question, but simple question for the patient, whether neoplasia is present, yes or no. You see there was almost perfect accuracy, meaning that there's a high correlation between mucosal biopsies and endomicroscopy. For a longer time, there was the problem that we just could say neoplasia, yes or no. We could not grade the tissue, but if you add a different contrast agent, which is acraflavin, you even can see nicely the nuclei, and then it was possible for Silvia Sandoleano even to differentiate between low-grade and high-grade dysplasia. What does it add in ulcerative colitis? You still have to do chroma endoscopy to see the lesions or to unmask the lesions, but then you use endomicroscopy to see whether there's a need to do biopsies on that certain area, and then you see that with a 10 times reduction of biopsies per patient, so an average 4 biopsies per patient instead of 40, you still have this increased diagnostic yield that you have a 4-fold increase diagnosing intraepithelial neoplasia. And these data were most recently confirmed that chroma endoscopy and endomicroscopy add substantially in the diagnosis of patients with dysplasia, as well as in this study you see 4 additional dysplasia due to chroma endoscopy, and endomicroscopy had a high sensitivity and specificity. So I'd like to conclude my whole talk with a last conclusion. I think endomicroscopy is exciting, and the combination of chroma endoscopy and endomicroscopy really reduces the amount of needed biopsies, and only you will do targeted biopsies. If it looked normal with endomicroscopy, it will be normal even in regular conventional histology. And I think the door is also open, but that's not shown today, but I did it on the presidential lecture, that also functional and molecular imaging will be and is possible. Thank you very much for your kind attention.